let's just dive right into this explainer. We're going to break down the critical differences between seizure types and, really importantly, the high-stakes emergency protocols you absolutely need to know. Seizures can be one of the most terrifying events a parent, a caregiver, or honestly, even a seasoned healthcare professional can witness. But by understanding exactly what's happening in the brain, we can strip away that fear and replace it with decisive, life-saving action.
Think about that for a second. When we talk about kids in neurologic emergencies, your mind might instantly jump to something like a bad head injury or a dangerous infection, right? But you might actually be surprised to learn that the single most common pediatric neurologic emergency overall is an event directly tied to a child's body temperature.
Here's our roadmap for today. First, we'll cover the febrile seizure trigger. Then, we'll look at focal versus generalized seizures. After that, we'll get into the status epilepticus emergency. And finally, we'll wrap up with seizure interventions and therapy.
All right, let's kick things off with section 1, the febrile seizure trigger. So these are typically seen in kids aged 6 months to 5 years old, and there's a massive, myth-busting fact you need to know here. The trigger is actually the rapid rate of the temperature rise, rather than how high the fever ultimately gets. It's that sudden, dramatic shift that destabilizes the immature brain and alters its seizure threshold. In fact, parents often tell us that the seizure happened first, and the measurable fever didn't even show up until a few hours later. That's classic febrile seizure presentation, assuming, of course, there's no underlying central nervous system infection causing it.
Now, how do we know when a typical childhood event turns into a major red flag? Well, we divide these into simple and complex categories. Simple febrile seizures involve the whole body, they're super brief, lasting less than 15 minutes, and they only happen once in a 24-hour window. But if that seizure crosses the 15-minute mark, the symptoms are focal, meaning they're only affecting one side of the body, or if they happen again within a single day, we're looking at a complex febrile seizure. This is exactly when we need to escalate to an emergency evaluation to rule out scary things like meningitis, especially if the baby is under 6 months old. So the crucial point is how we actually handle this. Caregivers naturally want to give fever-reducing meds, like acetaminophen or ibuprofen, to stop the seizure from happening again. I mean, it makes sense, right? But here's the hard truth. While we absolutely give these medications to reduce the fever and make the child more comfortable, parents really must understand that about 40% of kids who have one febrile seizure are gonna have another one. And those antipyretics, they will absolutely not stop it from happening. Moving right along to section 2, focal versus generalized seizures. Let's see how this builds into the broader world of unprovoked seizures, separating those single fever-driven events from chronic conditions. To properly diagnose epilepsy, we have to look for recurrent seizures with motor or non-motor manifestations that happen without a direct environmental trigger. So no rapid fever, no hypoglycemia, or severe sodium imbalance. If a child has 2 or more of these unprovoked seizures and they're spaced more than 24 hours apart, that meets the official diagnostic criteria for epilepsy. Let's break down how to tell these different events apart, because the differences are stark. Focal seizures, for example, often feature strange sensory auras. Maybe an odd feeling in the stomach or some unusual smells, followed by a post-ictal state of confusion. Now contrast that with absence seizures, which we commonly see in 4 to 12-year-olds. With these, there's no aura, no fall, and no post-ictal state. Honestly, it just looks like the child is briefly daydreaming or staring off into space. Then, we have the incredibly dangerous atonic seizures, sometimes called drop attacks. This is where the child suddenly loses all muscle tone and violently falls forward, which creates a huge risk for severe facial or head injury. And finally, the generalized tonic-clonic. This is the most dramatic and widely recognized type, carrying a massive fall risk and a really prolonged recovery period. It's incredibly helpful to mentally watch a tonic-clonic seizure unfold chronologically. It begins with absolutely no warning, just an abrupt loss of consciousness. The first 10 to 20 seconds are the tonic phase. The entire body goes completely rigid, the eyes roll up, and the patient might even stop breathing and turn blue from apnea. Next up comes the clonic phase, which lasts 30 seconds to several minutes. This is characterized by rhythmic, violent jerking, incontinence, and possibly foaming at the mouth. When that physical seizure finally breaks, the patient enters the post-ictal state. And guys, this isn't just a quick nap. We're talking about hours of deep confusion, extreme muscle soreness, and total amnesia of the entire event. Okay, let's get into section 3, status epilepticus emergency. We are officially entering the red flag crisis zone now. Because what happens when that clonic phase just doesn't stop? 5 minutes. This single number is the absolute critical threshold. Any seizure lasting 5 minutes or longer, or a series of recurrent seizures where the patient doesn't regain consciousness in between, is officially diagnosed as status epilepticus. Status epilepticus is a true, life-threatening medical emergency, and why is that? Well, ongoing, uncontrolled neuronal firing puts a massive systemic metabolic demand on the body. The brain is literally consuming oxygen and glucose way faster than the body can replenish them. If this isn't stopped, it leads to severe hypoxia, which is a dangerous lack of oxygen, respiratory failure, and permanent, completely irreversible brain tissue damage. Because time equals brain tissue, our intervention sequence has to be aggressive, and it has to be immediate. Our absolute first-line defense is a benzodiazepine, like diazepam or lorazepam. And hey, if we don't have an IV line placed yet, we do not wait. We push it through buccal, rectal, or nasal routes, period. Only if the seizure stubbornly continues after that initial loading dose do we bring in our heavy-hitting second-line medications, like fosphenytoin, phenobarbital, or valproate, to forcefully break that electrical storm.
Which brings us to our final part, Section 4, Seizure Interventions and Therapy.
Now that we've navigated the acute emergency, let's map out our broader savior protocols and the absolute safety rules for managing these patients. When you're witnessing a seizure, there are very strict rules of engagement. You do clear the area of hard objects, and you do get the patient into a sideline position to allow saliva to drain. But remember these absolutes. You must never try to physically pin down or restrain a seizing patient. And despite those ancient, stubborn myths, you must never force an object, a spoon or a bite block, into their mouth. They are not going to swallow their tongue, I promise you, and forcing an object in there only guarantees broken teeth, airway obstructions, and further severe injury. Also, do not offer food or liquids until they are fully awake. Once the seizing actually stops, your priorities have got to be crystal clear. Using our ABC priority framework, airway, breathing, circulation, securing that airway by physically checking the head and tongue positioning is the non-negotiable golden rule. You need to confirm the airway is patent or open, and you do this the literal second the physical jerking stops. Actually, scratch that. Do it before you even reach for a blood pressure cuff and way before you shine a light in their eyes for a neurocheck. Airway is everything. Parents and caregivers of kids with epilepsy absolutely must internalize this exact list of when to bypass normal protocols and just call 911. We already talked about the 5-minute status epilepticus rule, but look at some of these others. Call 911 for apnea. If their pupils are unequal post-seizure, if they're vomiting continuously for 30 minutes, if they're unresponsive, or if it's their first ever seizure. But really pay attention to that last one, a seizure occurring in the water. Even if a child is an excellent swimmer, they must never be left unattended in a bathtub or a pool because a sudden loss of consciousness turns a seizure into a highly lethal drowning threat instantly. When it comes to long-term management, the medical approach is super methodical. We start with a single anti-epileptic drug at a low dose and titrate up. And here's a massive safety warning. You must never abruptly discontinue these medications because doing so can trigger severe withdrawal seizures. Patients should also wear a medical alert bracelet at all times. But hey, we also have amazing non-drug options for cases that resist medication. A strict ketogenic diet, high in fat, low in carbs, can actually alter brain metabolism to reduce seizures. For kids aged 4 and older, a surgically implanted vagus nerve stimulator can interrupt abnormal electrical activity. And in the most stubborn, medically refractory cases, focal resection surgery can physically remove the small area of brain tissue that's sparking the seizures. I'll leave you all with this final thought. Despite the highly dramatic, chaotic nature of these events, does epilepsy define a child's intelligence? Does it prevent a normal school life? No, it doesn't necessarily affect a child's intelligence at all. With the right medical alerts, the right safety protocols, and proper medication adherence, what stops these kids from attending normal schools, participating in life, and living completely full, normal lives? Honestly, nothing. Knowledge and preparation are what give these patients their lives back. Thanks so much for joining me on this explainer, and I'll see you next time.